Hello everyone, I'm Dr. ARPIT KHUSHWAHA, JR2, Department of Radiology, ND by Patil University, Navi Mumbai, and I'm going to be presenting a paper on periampullary diverticulum and biliary obstruction, its clinical and radiological perspectives on Lemmel syndrome. Lemmel syndrome is rare but significant cause of obstructive jaundice, occurring due to extrinsic compression of the intrahepatic common bile duct by periampullary duodenal diverticulum. While duodenal diverticula are frequently asymptomatic and incidentally detected, their close anatomical relation to the ampulla of Vater can lead to complications in a small subset of patients. Symptoms may mimic more common pathologies, including choledocholithiasis or periampullary neoplasms, creating some diagnostic challenges. Advances in cross-sectional imaging, particularly CACT, allow for early non-invasive recognition and differentiation of this entity, thereby preventing unnecessary invasive procedures. Today, we are going to present 3 cases of Lemmel syndrome with characteristic imaging findings and clinical features, underscoring the importance of considering this diagnosis in unexplained obstructive jaundice. So, duodenal diverticula occur in approximately 5 to 10% of the population, with incidence rising with age. The majority remain asymptomatic, but up to 5% may develop complications such as diverticulitis, hemorrhage, or biliary obstruction. Periampullary diverticula located within 2 to 3 centimeters of the ampulla of Vater account for about 75% of duodenal diverticula. So Lemmel first described the syndrome in 1934, attributing obstructive jaundice to extrinsic mechanical compression, papillary dysfunction, or chronic peridiverticulitis induced fibrosis. Clinical presentations range from vague abdominal pain to frank jaundice and recurrent cholangitis. Imaging is indispensable for diagnosis, differentiating this benign condition from malignant obstruction. So this is the case one. A 74-year-old woman without previous pathological antecedents was admitted to the emergency department of abdominal pain and vomiting since 15 days. USC of abdomen revealed dilation of the common bile duct, which measured 12 mm with IHPR dilatation. A complementary MR cholangiography was done, which showed a small diverticulum arising from the medial wall of the second part of duodenum, causing compression on the terminal part of CBD with moderate dilation of the CBD, common hepatic duct, right and left hepatic ducts, and intrahepatic biliary radicals, and cystic duct was seen. Then we performed a CCT, which showed an air in oral contrast filled periampullary diverticulum arising from the medial wall of the second part of duodenum, as you can see in figure 1a, exerting a mass effect on the terminal portion of the common bile duct, causing its upstream dilatation, as you can see in figure 1b, and central and peripheral intrahepatic biliary radicals. Lower insertion of the cystic duct was also noted. The diverticulum measured about 22 into 20 mm. The case 2, a 54-year-old woman was admitted to the emergency department for acute abdominal pain in the epigastric region since 20 days. She also presented with weight loss, vomiting, and fever, and was a known case of cholelithiasis. CCT abdomen revealed a periampullary diverticulum. The diverticulum contains oral contrast and air measuring 24 into 21 mm. It is seen compressing the intrahepatic common bile duct with upstream dilatation of the CBD measuring 7.2 mm. As you can see in figure 2a and 2b. A last case for the day. A 55-year-old man was admitted for abdominal pain and vomiting. CCT abdomen revealed cholelithiasis without changes of cholecystitis and focal outpouching in the periampullary region arising from the medial wall of the second part of duodenum, seen abutting the terminal portion of CBD, causing its upstream problems. Proximal and mid-pancreatic duct appeared to be dilated as well. Diverticulum contains oral contrast and air measuring about 15 to 14 mm. As you can see, I have labeled it for you. The dilated pancreatic and CBD and duodenal diverticulum. So Lemmel syndrome, though rare, should be suspected when obstructive jaundice occurs without cololithiasis or malignancy. Pathophysiological mechanisms include direct compression of the CBD by the diverticular sphincter of OD dysfunction due to anatomical distortion, periampullary inflammation, fibrosis leading to chronic obstruction. CCT and MRCP are pivotal for diagnosis, demonstrating a diverticulum with intraluminal air slash contrast abutting the ampulla and causing upstream ductal dilatation. Differentiation from ampullary carcinoma is crucial to avoid unnecessary surgery. Symptomatic cases may require endoscopic or surgical intervention, although symptomatic or minimally asymptomatic patients can often be managed conservatively. Lemmel syndrome remains an under-recognized but important cause of obstructive jaundice. Radiologists and clinicians should consider the entity in elderly patients presenting with biliary obstruction, particularly in the absence of gallstones or malignancy. Accurate, non-invasive diagnosis through CCT can facilitate timely and appropriate management, sparing patients from unnecessary invasive interventions. All three patients presented with abdominal pain. Two also had vomiting and one developed jaundice. USG showed CBD dilatation in all cases. MRCP and CCT confirmed periampullary duodenal diverticula, compressing the distal CBD and producing upstream biliary dilatation. Two patients had also associated cholelithiasis, but no choledocholithiasis or malignancy was seen. Characteristic findings included air contrast filled periampullary outpouchings abutting the CBD. All cases were diagnosed non-invasively and the patients improved with conservative management and follow-up. These are my references. Thank you.